My name is Phil Flanagan. I'm from the Northwest Melbourne Primary Health Network, and I work with Claire Hardy and other colleagues in the workforce development team, bringing you some of our education sessions. So thank you very much indeed for joining us today for our session, which is entitled How to Run a Scalable, Profitable and Sustainable Mass Vaccination Clinic Without Losing Your Sanity. And it's a very good title. There's just a few things to work through today before we get started. A few little basic niceties, but first of all, one of the things I'd like to do, please, is an acknowledgement of country. And Northwestern Melbourne Primary Health Network would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture. I would like to pay our respects to elders past, present and emerging, and to any Aboriginal and Torres Strait Islander people who may be joining us today for the presentation. Just a few little bits of housekeeping. I'm sure you're all very familiar with these now, having spent 18 odd months or so doing lots of Zoom meetings and training sessions. But we would ask, please, that all attendees at the presentation today, please keep your microphones muted. You can see the little icon there. It's just a courtesy to other people while we have the presentations taking place. This is, of course, an interactive session, and one of the things we really encourage is that you ask questions during the session via the chat box, and our presenter, Dr. Todd Cameron, is very good at keeping an eye on the chat box. There will be a Q&A session at the end of the presentation when we can address some of those questions, and we should also just point out that those questions will be anonymous, and that will protect your privacy. A couple of other little bits and pieces. The session is being recorded today, so it will be available for colleagues after today's live presentation. And just from a bit of a logistical and registrative perspective, if we could ask that your name is correct in terms of the way you registered today for the Zoom meeting, that just helps us to know who's actually attended and participated in the event today. Just a little bit of a plug for some upcoming education and training sessions that you may be interested in. All of the details of these sessions are on our website, which I'm sure you're familiar with, and if you go to our website, you'll get more details about those sessions. There's dates and times up there, as you can see, running through to the end of August, and you'll be able to register as well. So without any further ado, I'd like to hand over to our presenter today, Dr. Todd Cameron, who's a general practitioner and a founding member of the Modern Medical Group. You can see his intro there, and I'll also let Todd do a little bit of his own intro as well as he starts the presentation. Thank you, Todd.
Thanks, Phil. I'm grateful for your intro there. I am a fan of running meetings with a video on. So if you have capacity to turn your video on, please do so. I'd love to see your smiling faces. And as mentioned earlier, please remember to rename your profile. The way you do that is when you're looking at the screen, you'll see 3 dots in the top right corner, and you just click on that and there'll be an option rename. And then we'll find that we don't have Galaxy S20 5G or iPhone 11 Pro. It's much easier if we call you by your actual names and not your current operating system. So let's get some video on. This will be a much more useful session if we do so. If there are any people that would like a detailed intro from me, let me know. Just put a yes in the chat. But otherwise, I'm going to move on because this is all about providing value for you. And what we really want to get to here is how you can deliver profitable and scalable systems for mass vaccination in your general practice. Before I get to the meat of the session, what I'd love to do is get you to warm up your fingers in the chat. So just click on the chat icon, which is the little voice box, and I'm going to get you to put in whether you're a practice manager, just put P. If you're a GP, just G. And if you're an owner, put O. And that'll give us a bit of an idea about who's in the session. Cool. As many people as possible put in there, that would be great. And then I'm going to give you one more job to do. The next job is to tell us what vaccines you're currently offering in your practice. A, if it's AZ only, P, if it's Pfizer only, B, if it's both. All right, cool. All right, I'm going to get you to give yourselves a score out of 10 with how well it's running in terms of, being hassle-free, high volume, and financially rewarding. Give yourselves a score out of 10. Okay, Alison's not doing any. That's good. So this is to come along and see how it's going. Betty's giving the clinic a 9 out of 10. I like that. Let's get some more scores coming in. Good to see some video on. Let's get some more videos on if we can. Okay, cool. Okay, there's a good variety of how well people think this is going for them at the moment. All right, well, let's get to it. And then we'll see if at the end there's some different feedback. The reality with this stuff is it can be very, very tiring work. Even if we do it the right way, it can be difficult work. And we want to do our best to obviously smooth that load over. And one of the frustrations for us has been this guy. And the problem is not this guy himself, but it's what comes out of his mouth. There was a point in time where if you're a practice manager or a receptionist and you're watching the evening news and ScoMo comes on, he says, oh, listen, blah, 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 call your GP. That was kind of the default setting for everything. And then the next day the phones run hot. Now, I'm a fan of democratized information. The reality is if you gave information to GPs first, most likely it would leak anyway. That's not the problem, but it was when it would just be call us, and we're as new to the information as everybody else. This was an extremely frustrating thing that is still going on. It's probably not impacting us as much as it is, say, New South Wales and even Queensland at the moment. And there's often no reward for the risk. And so this part of the vaccine delivery has been extremely frustrating. Initially, the problems were that we didn't get enough volume. Then when we did get volume, there was down scheduling to AZ, mixed messaging, really poor public health messaging. And in the end, we just had demand waxing and waning and supply problems. It's been very difficult to run this. And guess who gets the hard job? Is it the pharmacists? Is it the mass vax clinics? Or is it GP? Give me your thoughts as to who gets the toughest gig in this. And then, yes, I've created a word, but there's this frustration. I think, we're all exhausted and frustrated by this. And I'm going to be really blunt here. We're only at the starting line with this. This is something that people probably haven't yet accepted that this will be an annual event. Likely, we will probably be doing these as annual boosters, and we need to get to a great number of people. And we're going to have to be creative to get to that last 25% of the population that we immunise. And I don't mean 100%, the last quartile of 85 or 90% or whatever it is we get to is probably going to require more time, energy and money than the first three quartiles. We're going to need to be creative, but GPs are very good at that. And when I say GPs, I mean general practices. So what we want to do today is we want to use some tried and tested models. Everything I talk about today has been tried Australia-wide, and I'm going to give you a variety of ways to deliver vaccines in your environment. Now, any excuse I can have to put a Richmond Tigers slide in, I will. But if you do this well, you're going to get to engage your team, and bringing your team along for the ride, for the journey, as they say, is really important for this because you can't do it all yourself. And you're going to need to communicate. It is not possible to over communicate. We often think it is because we get tired of telling people the same things again and again, but you're going to need to communicate with your team, with your team that are delivering the vaccines as well as those that aren't, and you're going to need to over communicate with your community. This is a really, really big impact piece. And if we do this right, you get to make an impact in your local community. You get to do that with really efficient use of your time and resources, and you can make a good financial return out of this. Who thinks they're getting a good financial return out of this? Just drop a Y in the chat if you feel like, you know what, we're getting a good financial return from this. All right, nobody's prepared to admit they're getting a good financial return. Now, you should be getting an awesome financial return from this. Why? Because you are making a big impact and you're putting extra work in. Do not be ashamed about making a profit from this, but you should be able to get more profit from the work that you do in one session on a weekend than you do in your whole week of general practice in most cases. So that is the ambition for what we should be achieving here. Right, the models that we're going to walk you through are designed to deliver between 60 and 80 vaccines per hour, up to 100 vaccines in almost any clinic environment. I really want to get a sense check here as to what the average number of vaccines per hour you are delivering in your clinic currently. So just drop that in the chat for me. And remember here, this is just about actually getting a bit of feedback as to where you are now So then we can chart a course towards where you might want to get to. So it doesn't have to be precise, but what's the average number of vaccines that you are delivering in your practice at the moment per hour? Just wait for that to come through in the chat. Okay, that's good. So there's a bit of upside here that is available to everybody based on what's come through there. Okay, cool. That's really good, actually. The first thing I'm going to talk to you about is the communication stack. Now, when we are doing high volume work, we must have low variability. Okay, that's really important. It isn't possible to do a lot of something when it highly varies. And so the way that you tailor your communications is going to be really, really important. And remember I said communicate. This is where you can nail it and allow yourself to move a lot more quickly because you're doing things in bulk. So I'm going to walk you through the way that we have designed our communication stack and how much of a difference that makes to our consulting and how it allows us to move to the high volume numbers that we're talking about there. Now, the first thing I want to say to you is when we are communicating with our audience, i.e. our community, we are only wanting to communicate to one group of people. So let's think about people in the community as traffic lights. The red traffic light is the easiest. These are the people that say, I'm not interested in the vaccine. They have some concern over its safety, or they might be anti-vax or whatever. Often it would be easy to say, I need to spend a little bit of time on convincing that person that this is the right thing to do. I'm going to argue that you should leave that person alone in the corner and just say, you know what, if vaccination is not for you, that's cool. You just wait and we'll get to you when you change your mind, or you just have to live with the consequences of not vaccinating. And the biggest consequence of not vaccinating is intensive care. We know that if we look around the world, that the vast majority of people in intensive cares at the moment are unvaccinated. And so that's a risk that people are prepared to take. That's fine. We used to spend a lot of time on this group in the past, mostly because we were trying to convince parents of the merits of vaccinating their kids. But if people want to make a decision that is a consequence for themselves, and they understand, and language is not a barrier, all of those other things being equal, and it's not about accessibility, then they can just wait. Let's not waste any energy on messaging to that group. So we're actually calling them out in their messaging, saying, we are here for the people that are green. Green means I'm in the eligible group. I can be consented through a fully digital workflow, i.e. they can follow the questions through the booking stack, and they're able to get into the practice. So green means they are ready and rocking, ready to roll. The next group to think about is those that are orange. And the orange group are just people that maybe have some questions, or they have some confusion, or they have some uncertainty, or they're just slow for some reason. That might be that English is not their first language. It might be that mobility is a problem. There might be reasons why they're not right for the high volume clinic. Now, this group you need to treat differently. Who here is using the 1066, the vaccine item number that's for consulting prior to giving the jab? Is anybody using that? Okay, I'm going to give you a controversial view that you should stay right away from that number. Because if you're going to do high volume, you need to do low variability. You need to push these people into regular consults during the week. I actually don't really care what you bill it, but in most cases it would be a 23 because you have no intent of offering the vaccine at the end of it. It is not part of your vaccination clinic, but I strongly encourage you not to pull people off to the side, have a 10 or 15-minute conversation as part of a high volume clinic. Just completely ignore that idea about having a conversation. If people come in and your messaging is clear that you must, when you book in, you must be ready to have the vaccine. You must be consented, either yourself or following a conversation with your GP. You must be able to come in and get it addressed straight away. Those are the two groups we're going to focus on, and all of our messaging is centered on them. Anyone who's read, tell them that they can wait, and when they're ready, you're ready for them. There will likely be some social consequences for that group in terms of what it is they're able to attend, in terms of their ability to travel, etc., etc. The next thing to work on here is in all of your messaging, you need to have a framework around what you want people to think, what you want them to feel, and what you want them to do. Otherwise, we're not going to connect to the right purpose with this. Now, is anybody here using video messaging? Is anybody here using videos as part of their communication stack with patients? Just give me a yes or a no in the chat there. Okay. So there's some really good opportunities here to level up the way that we're doing this because, as I said, we'll be doing this for quite some time. So the work that you do in laying down really clear communications means that people will have a scalable process, which is really what we want here. So the first bit of communication is between now and approval. Now, for the 2 vaccines that are currently in play, they're already approved. So this bit is done. But let's pretend that Novavax or Moderna or one of the other vaccines was to become available, and you would be communicating with your audience around the future likely approval and for what groups that might be. So you would just be talking about that, and you might do that in an email to your patient database. You might do that in a text blast to your database. You might do that on a Facebook Live. So you could do all 3 of those, which is just informing people about what's coming. So this vaccine type is coming. This is who we believe it's going to be for based on the information today. When you come in, and this is where you start to see exactly how you run your process. So in this communication, you want people to start getting ready for the comms that are coming about make an appointment if you're in this group. So here you might say, hey, we'll be running high volume vaccination clinics for this. These clinics, the appointment time is brief, they're fast moving, and they're a bit of fun. What we're going to need you to do is to download our booking app so that when this vaccine becomes ready for you, you're able to make an appointment and easily get a time ready for you. So we just want to really center around, we're addressing the people that are green. Anybody that's got questions should go over here. The red people, that's cool, stay in the corner until you're ready to come out. And then we're going to actually, when these people, when the vaccine does become available, this is the way that you can get access to it. It'll be this type of appointment. Please download the app. So you're just sort of getting people primed and ready for it. And we're going to reinforce this message a few times. So the next thing is that the vaccine is approved, but you don't yet have it. Again, it's much like the previous message, but saying, hey, that approval we talked about has come through now. Just remember, we'll be doing these in high volume clinics. I'm a massive fan of running high volume clinics out of your normal clinic hours. There are actually 3 or 4 reasons for this, but the main 3, if it's out of hours, you've got the whole clinic to use. Usually it's easier for people to drive and to park there. And you can use a lot more of the space to be more efficient. You'll also get a much more substantial, the $10 premium you get after 1 o'clock on Saturday, 8 p.m. weekdays, and all day Sunday. When you're running a high volume clinic, vastly offsets the higher costs for having staff, and it's easy to get extra staff. Not necessarily your own staff, but it will be easy to get extra staff on those extended hours, provided that you pay them well. Does that make sense? Thumbs up. Is anybody doing these out of hours? No? Okay, right. So the in-hours stuff tends to be the really slow stuff. So we'll get to that in a moment as to how we can make some improvements on that. So here you're just talking about the COVID vaccine's been approved, reinforcing some of the messages that came across in the first one. And then we're getting to approval to roll out. So something's been approved, but the vaccine hasn't yet arrived, or at least it hasn't yet arrived for the group that is currently eligible for it. So we're just informing people that it's coming, building a bit of response potential. This might be where you say to people, we're going to be running these sessions at this time of the week, in this location. This is where we'll run it from. This is how the clinic will run. And just talk to them a little bit more about what a high volume mass vac clinic looks like. Sometimes you might attach a video, which is you walking around the clinic as it's laid out for the vaccines, depending on which model you use. And we're going to go through 4 models that you can use in a moment. And then we'll get to the bit where we actually talk about, okay, the rollout is now active. So we are now actually in the process of getting to the groups. And then we've got to make sure that in that rollout one, that we're telling people who the eligible groups are. And in this message, we would share the eligibility checker, usually linked to a PDF, which is a government PDF. And we include video in every single message we send. So there's always a video that people can watch, which is just summarizing everything I've just talked about. So here we're starting to seed what people can expect when they come in. And so in this circumstance, you would say, when you make your appointment, you've got to make sure that you're eligible. You've got to make sure that you bring a current Medicare card. Photo ID is usually good to ask for in this part, particularly with people kind of, I think the kind of hierarchy that kind of exists in most people's minds about Pfizer and AZ has created the kind of fake ID wars for older people again, where people are wanting to try and get something that they perceive to be superior, and so they're prepared to go to whatever links to get that. So it's really important to seed exactly what you're going to be doing to verify whether people are parts of appropriate groups and whether they are part of the eligible group based on age. So photo ID and Medicare card is really good to repeatedly mention that you will be using and checking at the appointment, and that people that don't meet the criteria, you should be fairly specific about what happens to people who don't meet the criteria, because otherwise you're going to have problems with, when you offer two different vaccine types, there's likely to be issues around that. So make sure that you're seeding everything that is relevant then, and that is where that people would make their appointment. Then the first reminder should come the day prior. The reminder is a really important opportunity to remind people the location of your practice. So you could embed a link to Google Maps. Remember, a lot of these people, there's a chance that they may not be existing patients of your practice. So you want to make this easy for them. You also want to simplify here. So we tell all patients the vaccine will be in your left arm. We don't leave any room for doubt about that, because remember, high volume means low variability. So wear appropriate clothing, wear a mask, bring your Medicare card, bring your photo ID, come 15 minutes early to make sure that you get the appropriate park. And if you are unwell, please cancel and rebook your appointment. Do not attend. You cannot say that too many times, because the last thing you want is having a tier 1 exposure site because somebody shows up with COVID. Now, at the moment, that's not likely in Melbourne, but the reality is if we were conducting these vaccination clinics in Sydney, there would be a reasonable chance. That's another reason to run this on weekends with a really lean team, because if something happens where there is COVID, you haven't exposed your whole clinic to that. You haven't had your whole medical team, whole reception team exposed to it. And so it means that you are much more likely to have a sustainable business afterwards. So when you send the appointment reminder, again, remind people about what to expect. It is only for people that have consented, that understand the pros and cons of the vaccine, and they don't have any remaining questions. Here you reinforce, if you have a question, please exit, speak to your GP, and come back to this appointment type when you are ready to make that commitment. How are we going so far? Is this clear? Do we need to slow down? Let's get a bit of feedback in the chat. I'm giving you a fair bit of information at a high velocity, and so I just want to calibrate to check that what you're getting is useful and good. Awesome. Okay, so the appointment reminders might give people a bit of the video here might give people a brief walkthrough about what to expect. When you come here, sign in here using the Vic Services app and follow the concierge to the right place. All of that kind of stuff you can see here. But you can see the importance of embedding all of these communications in the reminder stack that goes out to people. Otherwise, this stuff just gets left for the reception team to talk about, and it's one-on-one conversations 1,000 times. Every month you're having these conversations in great detail. The on-the-day appointment is a pre-arrival one, is just to say you've got your appointment today. This is the time, just like you would normally get for a reminder, and then just a reminder of all those things. Wear a mask, get here early, get a park. If you're unwell, rebook your appointment. Do not attend. Make sure you're consented. Photo ID, Medicare card. A little bit of a checklist in there, and then you're just giving people exposure to the same information as many times as possible. That way, you're just much more likely that it sticks. One of the problems with this is we don't like to repeat ourselves because we feel that we're annoying people. The reality is that if you're a teacher, you would know that most messages need to be repeated 8 to 12 times before they stick. So we need to be thinking in the same way. We need to repeat the messaging. Post-vaccination. So we send a text after the first or after the vaccination, and our text message says, "Well done." If that's your first, you're halfway there. Make sure you've got a time for your second. If it's your second, well done. The video just says, "Woo! You know, you've made an impact by becoming fully COVID immunised." That's awesome. Keep an eye out for side effects, and then we would link to documentation around side effects, particularly around TTS. This is really important. Now, in a moment, I'm going to show you a tool which is my absolute favourite tool that will help to neutralise a great many of your fears around how it is that you communicate risk with patients, given the TGA and the APRA kind of restrictions around advertising. But the post-vaccination message should also remind patients that they will receive another text message from either the government tool that's available or SmartVax, just to actually ask them about whether they've had any symptoms or side effects, and please to complete that because it's used for research purposes. So this is where you see the fact that they will receive a text message that comes from your clinic, but it's not really from your clinic. It's from a third-party organisation, which is just purely centred around gathering data, and that's important. So we also have a loop recording running in the waiting room in the area where people are waiting for their vaccine, just so that consent video runs again and again and again. And when it's AZ, it just talks about TTS, basically about what you need to be aware of, what things to look out for, and to make sure that you see a GP as soon as possible. If the general practice isn't open, then it's something for the ED. Now, updates are really important. We would usually do this every 1 to 2 weeks. So updates are, it can be an email, it could be a video that you send people, or it could just be a Facebook Live. And you could do all three from one thing. So you could do a Facebook Live, you could have that transcribed through Rev or some other transcription service, and that just could be turned into a blog and posted out, emailed out to your patients. So I'm lazy. I like to do things once and split it up and do it in many different ways. But your update will say something like, "Hey, at clinic, at the High Street Clinic, we managed to run our Pfizer and AZ clinic last weekend. We did 240 Pfizer, we did 60 AZ. I really want to give a shout out to the team members that did this. Dr. Smith and Jim, the practice manager, or Jane, the practice manager, the person who led the Vax clinic. Thanks to our nurses. Name the people, thank them for their contribution, share some lessons. One of the lessons was the feedback on the day was that it ran particularly well. We had a little bit of trouble with parking, so we've just changed the way we give advice to people for parking, and please get here 5 minutes earlier. A couple of people rolled up without masks. Luckily, we had some masks on site. Please make sure that you bring your mask with you. Whatever lessons you get from your last session, just embed them in this. This is just a narrative around, okay, this is what we're doing. This is why we're doing it. Maybe you might talk about what's going on regionally with the vaccine numbers. You might talk about what's going on nationally with COVID numbers. Just put a little bit more information in there, because if you do this really well, you're a curator of content for your community. And if you have got a clinic page on Facebook, Facebook Live is the best way to elevate your organic reach. Who's using Facebook Live? Yes or a no in the chat. So one thing that's worth keeping in mind, if you're going to do any marketing or put any money behind a post on Facebook, you need to organically warm up your audience if you're going to get the highest return from any money you put behind it. Zuckerberg will happily take your money that you want to throw at Facebook for marketing, but if you don't have an audience that's prepared to listen to you, just pay a lot more to get any reach anyway. So these are a great way of actually getting some engagement. And it's really funny. People often think, I don't really know what to say. One of my hats is coaching general practice owners in business success. And one of the guys is really dry. He literally had his phone turned on, and it was the nose hair view, and he was just reading from some of the content that the government had produced. He got about 5,000 views on YouTube for that. in a rural area, just because people were really dead keen to hear some content from somebody that they know, like, and trust. So just get out there and start giving some information to people because they're really keen to hear it, and that's important. So make sure you do the updates, probably every 1 to 2 weeks for those, just to keep people on the keep them regularly updated as to what you're up to. The blast comms are really important to have ready to roll. So, you know, running a mass vax clinic is a little bit like getting a plane ready. We want to sell every seat, and then imagine those people only paid when they got in their seat. We want to make sure they all turned up. So, you know, the first thing you want to do is you want to fill the vax clinic. The second job you have is the turn up rate. And that's also the purpose of that comm stack, is to make sure you're regularly communicating with people so they can't possibly say, oh, I didn't know I had that commitment, right? So you want to make sure that you have a tool to fill up the last bit of the clinic if it turns out it's not full. So if you didn't fill it with your normal marketing, or you had a bunch of people not turn up, or maybe you just had a whole bunch of 7 doses you could get out of Pfizer or extra doses out of AZ, but you might have capacity to do some extra work. You need to have your communications built and ready to roll to get those people to come in at really short notice. So, you know, again, your Facebook post that says, hey, we're running this clinic, we've got an hour to go, we've got 10 more doses of this left. We don't want to waste it. We want to put it in arms. This is the link you need to use to book it, and you've got to get off your backside and get down here now. That's the type of message you're going to be putting out regularly, to just have a blast message. Now, you can determine what you want to do with this. I would still tell people to make sure that my philosophy of this is, I would still tell people to make sure they're eligible and they're in the appropriate age bracket. But the truth is, if they turn up and they're not in that, and this is about either throwing stuff in the bin or putting it in arms, I would argue that it's better in arms. You need to make that choice yourself. And I would certainly say to somebody, if they came through this pathway and they weren't in the eligible group, that this is not something to go and announce publicly, because it will likely cause you some frustration and challenges if that's to happen. Are we good with that? Does that resonate with everybody? Are we okay with putting it in arms rather than in the bin? Yep, thumbs up. Or no, thumbs down. You think you'd rather adhere to the rules that are there? What are you thinking? All right. Now, one thing that I think is important to talk about is that one of the areas that has been a bit of a challenge is that the federal government has talked about AZ being phased out after October. That's caused 2 problems. One is that people may have had their first dose and they haven't yet had a second dose, despite it being more than 12 weeks. The second issue is that there's a group of people that believe that if they wait it out, they'll probably get offered something else. Now, we don't actually know if that's true or not. So the reality is we still do need to be pushing AZ into that group over 60. And we need to be making sure that we're clear about the clinics still being open for this. If you're concerned about the demand for AZ clinics, though, what you might do is stick it on the end of a Pfizer clinic. So here what we're trying to do is pick a block of time that is enough that you can make sure that you allocate your resources appropriately. Like, let's say it's a 5 or a 6 hour shift and you're trying to knock out 60 doses per hour. Let's keep it neat, 5 hours, 300 doses. You might say the last 60 doses we're going to make AZ. So the last hour of the clinic will be an AZ clinic, and you need to change something to say, you know, there might be a 10, 15-minute pause between them, change the color, change it so that it's clear that it's a different clinic, but it allows you to run that clinic in the same session and not then have to go and allocate resources for a clinic where you have less demand. Is anybody managing that problem with AZ in that way? So is anybody finding that there's tacking a bit of AZ onto the end of a Pfizer clinic? Just give me a yes or a no in the chat, just so that I know where you're at with that. Or are you still tending to run them as standalone clinics? Which again has some appeal, right? Because we're kind of then protecting ourselves from the reality that somebody might give something wrong. So there needs to be a pause, a changeover, and get going with the next thing. A little bit like a function center, you know, when they stop and go from one event to the next. That's pretty well how we want to run that. So, okay, now the next thing we're going to talk about is the environment, because the environment, the type of clinic and the layout you have, the available space will greatly determine what model works right for you. And there are several different models we can use. The first model is the grid model. And when you look at most mass vax clinics, they are using a grid model, but they're using a really resource-heavy grid model. Who's been to one of the state government mass vax clinics and done a head count of staff in the clinic? I want you to share how many staff you reckon you've noticed, because if you're running general practice, I'm sure you're paying attention to this, right? So tell me, how many staff do you reckon you've seen in there? Yeah, lots. Huge numbers of people, right? And mostly what happens is you've got one nurse seeing one patient and doing one vaccine every 15 minutes or so. You may know this, but there's been a few local EDs that have been on bypass because all of their own staff have been sucked away to the state mass vax clinics, and they're incredibly inefficient. But they really, really do not run particularly well. And so this is where we can really hit it out of the park with the efficiency. So the grid model works for a really big floor plan, and we'll walk through exactly what the grid model is. The cubicle or the room model is one that probably most people have used for when they've run flu vaccine type clinics. And that probably allows you to get somewhere between 15 and 20 per hour easily, maybe up to 30 per hour if you have a really good coordinator running that. And then the third model we're going to talk about here is the love child of the grid and the cubicle, which we call the grubicle. The grubicle is actually pretty cool and works pretty reliably. I think we've got somebody that's unmuted, so I might get you to just check the mutes there and make sure that there's not. Sounds like somebody's throwing things into a bin. And then so the grubicle is like a theme ride. So what happens is usually 5, 6, maybe as high as 10, depending on how big the room is. You'll have a large number of people enter a space, and then the vaccinators go through the whole audience, and you would have any conversations with that crowd before you actually go and vaccinate everybody. So you're moving people in. So it's a lot like a theme park ride. 10 people go on the ride, or 5 people go on the ride, and then 5 people exit the ride. The next 5 come on and they go back into the waiting room. So this is a really efficient model for using, just say, a treatment room only. And with using a treatment room only with this, if you can fit 5 people in the treatment room, you can do 60 people per hour with this pretty well, with 2 jabbers and usually 1 admin person. Is anybody using this model, the grubicle? You might have called it something else. We just named it that because it was the love child of the grid and the cubicle. All right, let's get a little bit of feedback as to what model people are using. Anybody using grid or the cubicle or room model or the grubicle? Just put some thoughts as to which model it is that you're using. Cubicle, yep. Cool. As much feedback in here is useful because this is where we get to upgrade your performance. Room, yep. Okay, cool. We'll do a bit of a teardown of the individual model types in a moment, just so we can see where the opportunities for efficiency are here. But the grubicle model, as I said, can reliably, you can reliably deliver around about 60 jabs per hour, sometimes as high as 100, depending on how big the room is. And you usually need 3 admin, 2 nurses, 1 to draw up, 1 to jab, and 1 GP. So it's a pretty lean model. And this is my favorite tool. Who here uses Loom or knows what it is? Loom is what I do all of the video content that I do on. And Loom is beautiful because you can do a screen recording with a little cutout of your face. And so, say, for example, you are concerned about talking about, the side effects of AZ. All you would do is open up the government page with all of the government documentation and literally read out the page, but give a little bit of context to it. So when you say, these are the people that shouldn't have AZ, heparin-induced thrombocytopenia, That's just a ridiculous thing to have in any government documentation. I understand that people need to know what it's called, but it doesn't really have any meaningful context. So you would then say, these are the reasons why you shouldn't get it, the 4 reasons, which don't include all the other stuff that people invent. And you walk through how, the common causes of clots, DVT, etc., strokes are not contraindications. You would read that out. But as you read it out, you just give a little bit of extra context, and that becomes part of your video content that you share with people, either on your Facebook page or in the message that you send out, whether that's email, text. It doesn't really matter how it gets there, but it's just a way of you gathering data and using the formal documentation, but adding your personality and context to it. I think I've got sort of 500 odd videos on Loom. I use this for a lot of asynchronous comms in my team as well. So yeah, get to using Loom, really easy to use, and you'll find it adds a lot. One thing with Loom is it's shareable video. So if you text somebody a Loom, they can share it with other people. So literally just copy and share the link to somebody else. Now, you're also going to need to consider your workforce. Who is it that you have now that you can extend to do extra hours for the vaccine delivery? Remember, as I said, you're going to be doing this a long time. So there's really 2 ways of you approaching this. One is that you retask your existing team. The odds are that you've got a nursing workforce that is really busy, and there's probably a backlog of chronic care from last year that you haven't yet got to. So if you're doing 8 an hour and you're getting 1 or 2 people vaccinating, you're probably drawing that team away from the high impact work they could be doing with treatment room or CDM, all of the other things that they would normally do. They're just going to be pulled away from. And frankly, in the end, you're just going to piss them off. They're going to become really annoyed at the fact that they can't do the things they want. And if you're doing 8 an hour, you'll just never get to make a meaningful impact on your local community. So you're much better to do an abbreviated model whereby you have a high impact time, you get in and do as much as you can, and then get on with your normally daily work. Let me just move across to a little bit of discussion on the different models. So this is the grid model. And if you're running a grid model, it'll be 5 across and it will be 7 deep. There are always 2 buffer rows, because we know that if people don't have buffer rows and something runs over, you will end up, and essentially what happens here is the patients sit in the chairs and they remain stationary, and the jabbers move in from the sides. Whoever gets to the first row first jabs them, and as effectively what happens is they would move in with carts. So they're just jabbing, put it in the bin, jab, 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 next row, jab, jab, jab. At the end of the row, there's a timer that's set that says 15 minutes, they all go. So this is like that, 5 moves on, the next 5 moves in their seat, and the rows just circulate around and around and around. And this is how most NASVAX models should work, but they don't, because what they do is they put them in little cubicles. They actually do the worst hybrid of all. They put them all in little cubicles and leave one person in there who just does 4 people per hour. This model can easily deliver 100 vaccines per hour, but you need a fair chunk of space, because in this little area here, obviously you need to have 1.5 between all these. So you end up with 6 meters, and if you're going to have a bit of space to circulate around the outside, by the time you get to the end of it, it's 9 or 10 meters across, and then the depth is a little bit larger again. So you kind of need 10 by 14 meters of space that's pretty clear, and you can move around that fairly easily. But if you have that space available either in your clinic or a space that you can co-opt for a period of time, the grid model works pretty well. And the main thing that you need is somebody off to the side in admin that is actually managing the exceptions. So the way we do this is that we have the appointments all manually on a sheet. If somebody was to get the vaccine in their right arm, we would mark that. But otherwise, the admin person is just punching all that information into the system. We use a tool called a Stream Deck. Does anybody here use a Stream Deck? Get a yes or a no in the chat. If the question is, what's a Stream Deck? We'll get to that in a sec. Now, it is called an Elgato. Stream Deck. And what that does is it's a string of macros. So it basically means that the data gets entered that says the patient came in, this was the process, they received this vaccine, this batch number in this arm, and that's all done at the click of one button. So that macro is done straight away so that you completely remove the need for, again, high volume, low variability. Remember, we've got to have those two things. And so this way, the trolleys move down and the two jabbers just approach from the sides, empty sharps in the bin there. That's one model. And as I said, if you've got a large format floor plan, you can knock out 100 per hour fairly easily with that. And so, you know, over a block of time, you would do a reasonable amount of work. If we go and look at the cubicle, so an upgrade to the cubicle system, you should have, the cubicle should be that everybody is lined up outside the door and they know exactly what sequence they're going into the room next. So this is my best attempt at a consulting room. So they come in, this is the exam couch, and this is the desk. So you've got two people, you got a jabber, and you got an admin person. Now, depending on how you ran this, the admin person could be the GP, and the nurse could be the jabber, or it could be that it's an admin person and a GP as jabber. So if you're going to use this model, you do not want your most loquacious GP in there. You just want somebody who doesn't speak much, gets people in, gets the vaccine in, gets them out. And then the person that's doing the admin can punch all of the data in. That's essentially what their role is. So it's in and out really quickly. If you do this well, you could get up to 30 to 40 people in the room well, but you're going to need, you know, like a cattle dog out in your waiting room, because they have to put the people in the waiting zones to wait. And usually they would set a 15-minute timer on their own device. That's probably the easiest thing to do. And they're in an area where there's somebody who's surveying the area. So, you know, it's a little bit like, imagine that there's a surf patrol and there's that person in the hut. That's what's happening in your waiting room. Somebody is there watching to make sure if there's any complication or any problem that it's jumped on. Now, it might be easy to think that person should be a nurse. The reality is your admin team do this every day of the week. They keep an eye on the waiting room. If somebody faints or says, you know what, I feel sick, I might pass out, they're the ones who manage that. So you just say to them, your sole job, but this is like having kids in the swimming pool, right? You don't say to somebody, your job is to cook the barbecue and watch the kids. You have one job. Your job is to keep an eye on the waiting room. And if anybody at all looks like they're not right, you got to go and attend to them and check on them, and then get the drawing up nurse to come in, would be the first port of call, and then the GP would be the next port of call. We clear so far on how that works? Just write GTG, good to go, if you're happy with that, or if you want to spend a bit more time talking about the cubicle model. And obviously here, the capacity constraint is how many people you can have waiting in your waiting room. All right, good to go. Let's move on. So that's one model, and you can probably amp up what you're currently doing. You could potentially have a space that's kind of outside under you know, some kind of marquee. You could have an alternative space that extended temporarily for this, if that's the main limiting factor. So the Grubicle, again, that's the main one that we use in our practices, and we reliably knock out 60 per hour. Now you can see the difference. If you're knocking out 60 per hour and you're doing it on the weekends, then on average you're probably $38 per jab. You do the math there, but you're billing around about $2,000 to $2,500 per hour. Your costs are not going to be anywhere near that. So you can see that you can run a session here that works really well. The key thing with the Grubicle model is, again, spacing, and you need to be able to move people out to the waiting room. And so there is a concierge taking people in and out. And once they're all jabbed, and literally you'd stand up in front of the people and say, you've watched all of the content, you've seen all the documentation. Does anybody have any questions prior to receiving their vaccine? That's it. It's the only thing you say. Our team just say, a lot of them would just say any questions out, because people get the information so many times. We're not saying the same thing 1,000 times only. And you could easily build a comm stack that was just for AZ under 60 to cover off on that group that often need a bit more discussion. The truth about consent is we really use the wrong word. It's just about receiving the right information. None of us can take the risks away. It's about people making an informed choice. And so we could easily just say, okay, here's a communication stack we're going to use for people that choose to get AZ that are under this age for a variety of reasons. Provided you can pick out those 4 rare contraindications, that's a valid approach to take to this. So make sure when you use the Grubical model that where people are waiting prior to going in, you have a screen, you run your loom that just talks about what to expect in there. When they go in, again, green lights only. If anybody sits down and says, I have a question, that is not the place to answer it. So if it's just, can I drive my car or something this afternoon? Yep, that's easy. But if there's any detailed question, like go out, rebook, we'll see you next time. Do not engage people in 10-minute conversations here. Just rebook them and do it again. This is where the stuff that the government provided us was asked for by our big bodies, completely useless. So that all needs to be done beforehand. Now, I want to share with you a model that we've named after one of the members that we coach, Annie. Annie is in New South Wales, and she runs a clinic. She owns a clinic. She's a GP that has 5 consulting rooms. This is a modified house. Her waiting room is literally the old lounge room, and her consulting rooms are bigger than the lounge room. So, you know, when she showed a photo of her lounge room, well, waiting room, we'll call it now, there were 4 chairs in there. So who can relate to this? Put in the chat if you have a clinic that you would consider tiny. And so far what I've talked about, you think, I'm not sure. Just give me tiny in the chat if you feel like that is something that is relevant for you. Okay, I love the tiny ones. All right, here we go. This one's really cool. So Annie in her clinic knocks out 70 doses of vaccine between 7 a.m. and 8 a.m. and then she gets going with her day. Imagine on the day, on the 1 hour in the morning, making a bigger profit than you do probably for the 3 days prior. 1 hour in a 5-room clinic with a waiting room that has 4 chairs. Does that sound appealing to anybody? You want to hear a bit more about how that works? Just give me a yes in the chat if you're keen to hear how that works. All right. So let's go through this because this is really cool. So what Annie's done in her clinic is the rooms are self-contained vaccination units. So most rooms, you can fit 4 people in there and have them socially distanced, but they're literally in each corner. So you may need to remove your exam couch just for the purposes of this. And when I say remove it, obviously put it somewhere that you can put it back in later. You don't need to go and turf it or put it on eBay. So you can put 4 chairs in there. And now what happens is the patients stay still. They don't leave. But what happens is you enter the room, jab, 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 do your 4, or if it's big enough, you might be able to fit 5 in there like the Grubical. They stay put. Nobody moves. At the end of it, the timer gets started, 15-minute timer. You've got a little kitchen timer in each room, and bang, at the end of 15 minutes, everybody goes. And then the process is begun again. So all that happens is the jabbers move from room to room to room, and you could easily knock out 60 or 70 here in a really small clinic in 1 hour. Now, again, you can run this for longer, but she does that obviously because she gets access to the item numbers that are higher rebates, 7 to 8 a.m. And this is a model that, again, tiny clinics can use to smash out really big numbers in their practice. And again, if you ran this on a weekend, same thing. You just keep loading up on it. As long as you've got somebody that's running like an usher, concierge that's running good time on the floor. Again, you could do this with people that have mobility problems. You could have one room put aside for a slow stream, people that, you know, come in a scooter or have, you know, one thing you could do at the door is somebody comes in, you know, there's always going to be somebody who comes in the least appropriate clothing for a vaccination clinic. You know, you think, man, is that just like, why are you wearing a jumpsuit? And then there's somebody else that's got their singlet on and they're ready to roll. So when one of your check-in team sees somebody that has the jumpsuit on, they just say, well, you're in the slow stream. You're in that room. That room gets done every second cycle, not every cycle. So you plan on that room not taking as many people. That makes sense? So you kind of got a plan for how you might be able to deal with the stuff that's a little bit slower than the others. And all those people have a bit of a chat in there. Now, the door stays open and it's pretty clear in the room. You just go, if one of you gets in trouble, just give us a hoot. the odds that all four of them end up having anaphylaxis together are pretty remote. And so somebody is in there managing people in and out of the rooms. And so it's not going to get you into any trouble because, again, there's people supervising somebody coming in and out of the rooms regularly and just making sure you set those 15-minute timers. The feedback that people get from doing these types of creative models is awesome. When you see the stuff that comes on their Facebook pages about how well things go, it makes a huge difference. So who thinks of the four models, I'm just going to get you to put in there the model that you think is going to work best for your practice. So we've got the grid, the cubicle, the groupical, or the anical. Which is the one that you think you would like to use? All right, cool. Let's get some more in there. Too many people treating this like a podcast, listening in the background, not actively listening. You have to come back to it later. But the anical looks like a winner there, so you can get a good idea about how that works. Obviously, you've got to use your nurse intelligently. The way that I would tend to recommend you use your nurse is that your nurse comes in early to begin the drawing up process, and you will know this if you've run a few clinics. Pfizer is a bit more involved than AZ is. And if you use the right technique, you can get the extra dose out of both of those most times. So make sure your nurse comes in and they are not distracted. They are able to get in early. Ideally, if you're going to run a 5-hour session, so the way we run these is we do 5-hour sessions. We use the Grubical. We do 60 per hour. The nurse comes in an hour early if it's AZ, and their ambition is to draw up enough for the first 2 hours of the session, and then during that 2 hours to draw up enough for the rest of the session. So they are effectively acting as your lead agent, and they always have a buffer of an hour worth of vaccines drawn up. That should almost always be a nurse job. Do not get your GPs doing that job, because the expectation of remuneration is much higher for a GP than it is for a nurse, and that is why often we would have one nurse drawing up and one GP and nurse combo, the GP nurse jabber combo. So get the nurse in early, make sure that they've built up enough steam so that there's a 1 to 2 hour buffer of vaccines pre-drawn. And then if there is some kind of a crisis in the clinic, that is the person that can go and attend to that and make the initial assessment as to whether this requires medical attention or not. That's the first most important thing there. Now, when you're running this type of clinic, you can afford to pay your nurses really well, or a nurse that is not a regular member of your team, but somebody that's been trained up to run just this process. Now, when we run a single process, it is very easy to train people up. You just need to build some great training content, and then to say, this is all you need to do. Follow the process. It's only one thing. You obviously want to do a bit of a drill on whether or not you need any anaphylaxis training, but that's about the only thing you really need to worry about. The admin team all need jobs. Again, this is something where you might rotate duties, or you might recruit extra people to work after hours. Be really careful about burning your team out. You know, this is a lot of work. I remember somebody relating a story where there's a professor stands up in front of the audience, holds aloft a glass of water. It's about half full. And the question that the professor asks the audience is, how heavy is this glass? And you'd expect there's a variety of answers to the question, but the real answer is it depends how long you have to hold it. And it's the same thing for these type of clinics. It really depends how long you have to do the sustained elevated workflow, which is why you need to go for high volume, high impact. If you do low volume, it just takes you so long to get any meaningful amount of work done, and you will displace normal work. But if you're doing high impact, high volume, then you have the funds. You can deploy more funds to recruit in extra staff just for that. So think carefully about how you do this. Do not get yourself into trouble with overworking people and having extra overtime. That might sound great for a short period of time, but if 2 or 3 of your key people say, I'm out, I'm burned out, I've had enough of this, then that's a massive, massive loss. And I think we're going to see that happening around Australia because people have underestimated it. GPs, look, you need a GP there to bill it under them. I know a lot of owners like to just have a nurse doing it in the background, 6 to 8 per hour. They perceive that that's a way of them retaining a higher portion of the billings. I think that's mostly a non-viable model. That should not be the foundation of the way that you deliver the vaccines, because you just don't deliver enough and you're depriving the rest of the clinic of that nurse time. When you engage GPs, my opinion, this is an opinion, is that they should be engaged as locums. What do I mean by that? Well, it should not be a retention of the billings, because this is a non-attendance item number. They do need to be billed under a GP. And so there's a conversation that needs to be had with GPs, but patients do not make an appointment with the doctor. They make an appointment with the clinic just to receive the vaccine. It is not like a normal consult. Because it's not attendance, some may be given by the nurse, some may be given by the GP. You cannot easily track this. So you need to pay GPs a guaranteed hourly rate plus GST and have a slightly different agreement in how you engage them for this work. Are there any questions around that? Because I'm sure that people probably have some combinations of old models sticking around with, GPs retaining a certain percentage, which is often why we throttle back the number of vaccines as well. Let's get a bit of a survey here. Are people engaging as locums? And as a locum, that means that you're paying them a guaranteed rate, or are people engaging as a contractor here? Just get some comments in the chat would be good. Both. Okay, that's interesting. I think I'm going to say both is the worst answer because you need some consistency. And, one of the reasons that GPs are engaged as contractors is independence and payroll tax. If you're engaging people that are doing the same job in 2 different ways, that does create some barriers. And so I would have a bit of a think about that. Again, you will be doing this for a long time. So if you've begun something that is actually non-scalable or painful to the practice, so, when you look at things, there have to be 3 entities involved in every decision. The patient has to win, the doctor has to win, and the clinic has to win. If you've got a system that the patient and the doctor win, but the clinic gets screwed, it's non-scalable and you cannot grow into pain. You need to reset it. And the practice has sole responsibility for messaging, for getting those vaccine appointments filled up, and for getting all of those people to show up. So that becomes a responsibility of the practice, and that is entirely as it should be. If you use the comms stack the way we've talked about it, that's not going to present any problems for you. So make sure you get the way that you engage your GP appropriate. Make sure you nail the appointment system. You are going to need to make sure that you use all of the available tools that we just talked about to get this done. You are going to make sure that you need to appropriately reward your GPs, and again, you block time out. You make sure that you don't burn them out. We've found doctors really love this when we've surveyed them. They really enjoy the work. It's pretty light on the cognitive function. It's pretty well paid, and it's a bit of fun because it's fast moving. And you're making a big impact on the community, which is really the main reason all of us got into healthcare. You are going to need to get your staging right. So you're going to need to know what areas in your clinic perform what functions, how people come in, how they're arrived, how they queue, where they sit before they're vaccinated, what happens when they're waiting there, how they get delivered to the vaccination area, and then how they come back to wait. You're going to need to make sure that you have a good idea about how all of that works, and that there's really clearly demarcated areas so that people know what they need to do. And the vast majority of people should be able to figure this out. So getting the staging right is really, really important. The delivery, at the end of the day, I strongly encourage you to experiment and to tweak on hacks to get the delivery improved, but it has to be that you measure these clinics as a standalone. So we have metrics on these, and our metrics are the doses we had available, the number of appointments that were available, the number of appointments that were made, and the show up rate. And then we also check the revenue against the costs for that particular session. So each of these vaccine sessions are completely scored independently, so we know where things are falling over. So we would clearly know that if we had a show-up problem, that we need to address our comm stack in getting those people to show up to their appointments. That becomes our primary focus. The observation area we talked a bit about, that's like I said, imagine that that tower on the beach where people are able to observe and see what's going on around them. That's really important to make sure that people understand they're being observed. If they have any questions or concerns during that time, you determine the mechanism, but raising your hand and making sure that somebody comes to check on you. As I said, I'm comfortable that an admin person does that every day of the week in general practice, and so it's probably an experienced admin person. It could just be, an ethnic mum as well that is going to just make sure that they look out for everybody to make sure they're okay. I think you also need to be creative here about what's available in the community that you might be able to get to just have some extra resources you can draw on to look after these areas, provided you've got an available nurse and available GP to attend to whatever it is that looks to be going wrong. And make sure you run some drills around this. So, nobody should be surprised if somebody does get a vasovagal or anaphylaxis at one of your vax clinics. It should be really clear what you do when that happens. So run some simulations beforehand, be really clear how you manage that, who does what. Again, like I said, when you've got high volume, low variability is critical, and just make sure that you nail all of the things that could go wrong. And then you can just scale these without worrying too much about it, because you know how to deal with every circumstance. Don't forget the second dose. There are a couple of ways of, I should say there are a variety of ways of managing how people get the second dose. I think when you're doing Pfizer and you're doing a 3-week gap, it's reasonable to stack the appointments. So when you come at 9 o'clock on a Sunday, the first time your next appointment is 9 o'clock 3 weeks later. That's an automated stacking process. I wouldn't do that with AZ if you know that 12 weeks is the spacing. And the reason for that is simple. It just means that in 12 weeks' time, you don't really know what you'll be doing. Most people don't know what they'll be doing. And so it could well be that the kids are now doing cricket in the morning. They can't get there for that. So you're going to be dealing with a lot of phone requests to change appointments. When it's a big gap, what we tell people is they'll receive a text message from us 2 weeks prior to the next vaccine, which just gives them a link where they can book only the second dose. And then we can corral those in an area that suits us. It might be that those were done on a Thursday, Friday, Saturday, Sunday, but we're only going to offer second doses on a Sunday between 10 o'clock and 12 o'clock or whatever it might be. We can then start to actually do, some dynamic appointments around where we corral all of that. Otherwise, you'll just have people all over the place. So I encourage you not to stack those longer appointment blocks. Does that make sense? Clear on that? I'll get a bit of feedback actually as to whether you're stacking. So just put stacked or rebook. Will tell me how you're currently doing it. Whether you're with the long ones, so AZ, are you doing those stacked at the moment, or are you rebooking them? Cool. Yeah, the rebook, you just need to make sure that you've got a good process for messaging that whole list from that day at the same time and offering them the slots that suit you, and don't give them too much choice. Make sure they come to your convenience. Again, I think that's important just to make sure that you can manage the future supply. All right, we come towards the end of the session. Now, one thing to keep in mind is Health Pathways does cover a lot of the information that you would need for COVID and COVID vaccinations. Don't forget Health Pathways. That is now, Sachin Patel is my business partner at Scale My Clinic. He's an absolute legend. He and I built these models together, and so I wanted to make sure that I did mention Sachin. If any of you have any questions about this, or you would like financial modeling on this, there's some resources I can share with you, but I encourage you to reach out to me on social media. I'm not hard to find. Just on Facebook or LinkedIn's probably the easiest, and I'll be able to send you some resources. When you make a request of me, please tell me what your role is, if you're a PM or an owner, and that would make my life a bit easier. What I'll do now, though, is I'll just check there's no more slide there. Yep, there you go. Q&A. I think that's it. I don't have another slide. So I'm going to turn off the screen share. And then let's just get the floor open to any questions. So if you've got a question, just pop something in the chat, and what we'll do is unmute you. And I don't mind what it's about.
Hi, Todd. Just to get things started, whilst people might be putting some questions in the chat there, we have had one that's come through in relation to density quotients in rooms, specifically in relation to 1 person per 4 square meters. I think you mentioned the 1.5 requirement rule, but I was just wondering if you could just elaborate a bit more on that, please.
Yeah, so obviously you do need to be considerate of whatever the local conditions are at the time. And that is where you might need to use some kind of external space temporarily to adhere to that. I think the challenge is that the vaccination environment is considered somewhat different from this, in that it's not elective. We do, let's be really clear, the only way out of the pandemic is through immunisation. If we were to drop immunisation off, we would see that there was a substantial worsening of everything that we're currently experiencing. So part of this could be your own comfort with running that type of a service. You won't see mass vax clinics changing anything during an outbreak, because their focus is on getting everybody through. So what you might do, though, is you might make a substantial change to the PPE that everybody wore during that time. So typically the patients that are in there would have face masks on. You need to be really tight with your timing. So on average, most people spend somewhere between 20 and 25 minutes in our building for this whole process. It's pretty efficient. They come in, checked in, jab, 15 minutes, gone. The amount of time they spend in the building is obviously important. If you can improve ventilation in the building, that's probably something that you should do as well. And you should make sure that there is airborne PPE on the jabbers. If there's any local community transmission, that's important. So, that would be N95s and P2s.
That's great. Thank you very much indeed, Todd.
What I might do while we're waiting is I'm just going to get, I'd like to know what has been most relevant for you right now in your practice. So just share your reflections of what has been most relevant for you. And there is a workbook, which I will share. Messaging, cool. Yeah, this all really goes together, because there's this problem, impact, outcomes, and solutions. So I'd strongly encourage you to use this. It's a really simplified way of saying these are the problems we're currently experiencing. This is the impact it's having. The outcome we want is this, and this is the solution that I learned from today. That's really cool. And I think that the things that have been shared there in the chat, the room layout options, that's just about utilizing the assets that you have. It's very easy to focus on what we don't have. And I hear people saying, I can't do high volume vax because I have a tiny clinic. We've just shown that somebody does 60 to 70 jabs the hour before they open. And I think that is possible for all of you. That's literally a 5-room clinic. So, if you were 3 rooms, okay, it might be 50 jabs you can do, but that's a fair bit in 1 hour, and you could scale that over a weekend to a bigger number. The communications, you need to spend time getting it right. If you don't get this right, it becomes non-scalable, because every one of those tablets is something that he has to say again each time. One of the things Web is that the Loom, the video that we do on Z and TTS in the room, heaps of people said, can I have a copy of that here with other people, because he's talking about it. And literally you can make it, it's just, this is the message, share it on with the people that you would like to have it. Now, I'm going to get you to, I'm sure you guys will do this yourselves. I like to get this information on a range of 1 to 7, with 7 out of 7 being super useful, 1 out of 7 being, didn't really make a difference to me. I'd love you to give a score for how useful today's session was for you right now. So a score out of 7, I just find that useful for me to know, okay, what do I need to do in future to change the way that we present information? Awesome. You're a very generous bunch. Thank you. There'll be questions that come back to the PHN. If there's something that needs some extra work, let me know. As I said, reach out to me on social media. Facebook and LinkedIn is the best. If you have a specific question that you would like addressed, is there anything that's remaining as a question that you'd like answered? And you can put your hand up or put something in the chat, and then we'll just unmute you. It sounds like people have enough information to go and make some change. I've got to say, I'm really grateful for all of you for being here. One of the things that is my personal mission is to elevate the position of general practice Australia-wide as being the centre of gravity for healthcare delivery. People like you all make it possible. This is something that is a really, really big impact piece. I think it's going to be really cool to be able to say to our kids later on, you know what, that massive pandemic that ripped through 2019 and 2020, well, I was there and I was part of the solution for this. This is just some strategies you can use to actually elevate your performance, make a higher impact, and hopefully not burn your teams out or yourself. And so thank you for coming along today. Please share how you go with reinvesting this knowledge. We often think that we learn from listening, but what we learn from is doing and then reflecting on that. So please share. And you can do that by tagging me in something in social media. I would absolutely love that. Or sharing it with the PHNers. I did these. This is how I came in. This is what I did, and this was the change for me. That kind of stuff is really, really exciting. So over to you, Phil. I'll stop talking now unless you need me to do anything else.
No, thank you very much indeed, Todd. That was a fantastic session. And if I may say so, on behalf of all the participants in the judging panel, that scoring there is fantastic. You've got another gold for Australia today. So thank you very much. That's great. The other thing I'd like to say is, again, I can reiterate your sentiments and thank everybody for participating today. We know people are busy. There should be an evaluation link coming through. I can see it now. My colleague Claire is so good at the work on these seminars and forums now. So there's an evaluation link there that we'd be very grateful, please, if you could click on that and send us your feedback as well. We can also send you the presentation slides from today's fantastic presentation by Dr. Todd Cameron. And as we just said earlier, just to reiterate a little bit of a promo, if you go to our events page, which is northwestmelbournephn.org.au/events, you'll get some information on some forthcoming education and training sessions that the PHN will be providing throughout August and in coming months. So once again, thank you everybody for participating. Thank you, Todd. Superb. It's been a pleasure to hear your presentation today. And thank you everybody for your time. And we look forward to seeing you at future events, because we can't do these without your participation as well. All the best, everyone. Have a great day. Stay safe.